Assalamualaikum everyone.
Assalamualaikum.
Assalamualaikum sir. Assalamualaikum sir.
How are you?
Walaikum salam.
So, are we going to start?
Assalamualaikum sir. तारिक साहब assalamualaikum.
Balsam.
सर वो जुमा साहब अभी ज्वाइन कर रहे हैं. जुमा साहब ज्वाइन. अच्छा आज सर आज के जो हमारे एग्जामिनर्स हैं जुमा साहब हैं और सीनियर मोस्ट न्यूरोसर्जन है, हमारे टीचर हैं हम सबके, और तारिक खान साहब हैं जो कि डीन है सीपीसी फैकल्टी के और हेड एग्जामिनर भी होंगे और जो इस्लामाबाद वाले सेंटर में, और मसूद साहब हैं जो कि यूके से हैं और हमारे रेगुलर मेंबर हैं. तो ये तीनों हमारे एग्जामिनर्स हैं और जो कैंडिडेट हैं वो डॉक्टर मुमताज़ हैं. तो मुमताज़ को हम सीनियरिटी देंगे और फिर सब जो नया पैटर्न है अब जुमा साहब के साथ डिस्कस भी कर लें किस तरह होगा और फिर उसके मुताबिक सर हम लेंगे एग्जाम उसका. तो जुमा साहब आप तारिक साहब से कुछ पूछना चाहते हैं तो फिर हम शुरू कर लेते हैं सर.
Tariq, Assalamualaikum. How are you?
Rashid, walaikum salam. Good to see you.
You too. Masood, क्या हाल है? ठीक हो?
जी अल्लाह का शुक्र है सर. थैंक यू वेरी मच.
Tariq Khan, are you in a position to enlighten us on what the precise format of the oral exam is going to be this time?
Yes. So, as you know that the talks are going to remain as they are.
Mm-hmm.
15 talk stations. So that will be as per previous protocols.
Mm-hmm.
Since we don't have any long cases and any short cases, so some of the talks would have a bit of psychomotor element to try and judge them on that. It will be very difficult, but you know, it will be a slight touch to it of psychomotor skills in the talks. Instead of the long case, it's going to be more of a discussion. It will be 3 cases so that we can finish them in 60 minutes. A scenario will be given to the student and then the student will tell us what sort of questions would he like to ask that patient, imaginary patient, and they call it interactive paper patient, if I may say. That's the name which they have given to this scenario. We would like them to stick to more of a targeted history and ask the personal history and the family history and social history if they feel it would be of any relevance in this particular scenario. So we can wrap it up in, let's say, about 20 minutes or so, the whole thing. So once they take the history, then we'll ask them what sort of examination would they like to conduct regarding that patient, and then they will tell us that they want to do this test, etc. And then we will go on to the discussion regarding probable diagnosis, differential diagnosis, investigation, management plan, and complications and surgical procedures.
Okay, so that's Tariq. That's very helpful. It's very helpful. So tell me, you want to get through 3 cases, and you're allocating 20 minutes for each. How do you see that breakup? In other words, how? I mean, you probably haven't prescribed it, but in your own mind, what was like of the 20 minutes? How long do you want to actually have a discussion on management, let's say, in the various aspects of management, and how long do you want to just give to the candidate to tell you that these are the questions I want to ask, these are the signs I want to elicit, these are the aspects of the examination I want to go through? So what, do you have any sense of that?
Yeah, so maybe you can say that maybe less than 50% of the time for the history and examination, and 50% plus time for the management and surgical skills and complications. But that to be, it depends on patient to patient scenarios.
Yeah, sure. Okay, that's terrific. Lal, तो ये काफी ये थोड़ा काम आसान हो गया, if you like. जो हम लोगों ने मसूद साहब के साथ last time जो किया था, तो we don't need to go in that direct. We don't have to have a simulated patient. लेकिन मुमताज, आप बात समझ गए हो?
Yes, sir, I understand.
So fine. So maybe if we can get started, Farooq will present the scenario of that. It's a 2-line just description of what the patient is, and then he's going to give you the he's going to share the MRI with you, or a CT scan rather, and then we can start discussing after that. Lal, ठीक है?
अच्छा सर, आज के तो हमने एक ही केस सेलेक्ट किया है, तो आया इस पे इसको कैसे करेंगे? वही 20 मिनट्स के मुताबिक कर लिया?
मेरे ख्याल में it is better to do it that way, because so that the students get primed for that sort of a an examination and management plan.
Yeah. So in fact, ऐसा करना Lal. Why doesn't Farooq, while we're doing 20 minutes of this, why doesn't Farooq quickly go take a WhatsApp picture of a patient scan and write the scenario and post that? मतलब you know, तो ये 3 cases डालना तो मसला ही नहीं है, 2 मिनट लगेंगे यार.
ठीक है सर, हम बीच में दूसरा तैयार कर लेंगे. ठीक है सर,
दूसरा and तीसरा दोनों.
ठीक है.
So that Mumtaz can have all 3 ना?
ठीक है सर, मुमताज will have all 3 cases. हम कैंडिडेट भी चेंज कर सकते हैं सर, कोई और कैंडिडेट भी बीच में ला सकते हैं. तो ये वाला शुरू करते हैं.
ये वाला शुरू करते हैं.
This is the scenario for the first case, sir. 45-year-old male patient presented to us with right-sided hearing loss. So this is the scenario for you, Dr. Tariq and Dr. Rashid. This is over to you, sir.
Okay. So first of all, I will greet the patient and introduce myself. Then I will ask the age of the patient, gender of the patient, and occupation of the patient, handedness of the patient. Then I will elaborate the symptom, whether the side of hearing loss is unilateral or bilateral, then the onset, whether it is gradual or the sudden, then whether it is progressive or not, when then how much he hears on the phone, and then I will ask about the tinnitus and loss of tinnitus, whether it is high tone or low tone, and then I will ask him how he speak. Does he speak very slow or he speak very loud? Then I will ask him from regarding the noise induced, like that he has worked in the noise induced area or machinery area or pass through area where bomb blast or the firing has took place. Then I will ask regarding the drugs, whether he has history of the drugs, ototoxic drugs. Then I will ask him regarding the ear trauma, earache, ear discharge, ear picking. Then sir, I will also ask from associative symptoms like vertigo. Does he has history of vertigo, or he has history of sway on the one side? Then I also elaborate these symptoms, and then I will go for the lower cranial nerves, like I will ask facial numbness, facial weakness, change in voice, increase difficulty in the swallowing the things, and then I will ask him regarding the raised ICP symptoms like headache and vision problems, whether headache is progressive and distributed in the whole head associated with vomiting or not, and increase with coughing and vomiting, coughing and straining. Then sir, I will ask for the exclude it for the neurofibromatosis. Does he has any the subcutaneous nodule or any family history of the neurofibromatosis? Then sir, I will ask for the drug history, any surgical history took place for the hydrocephalus, and so that will I will ask from him on the history.
Very good. Mumtaz, will you ask about the vision, the eyesight? Whether
Yes, sir.
it is deteriorated?
Yes, I asked. Yes,
You
sir.
did.
I asked in the raise ICP symptoms.
Excellent. Rashid, are you there?
Yes, sir.
No. Rashid Juma, are you there?
Mumtaz, this is a new situation.
Yes, sir.
And I think that what you, and you know, you immediately went into it. I think that it may be better to organize your mind around the way that you ask the question. And you remember, if you recall, it's
Right, sir.
you first sort out the presenting complaint. So
Right,
so
sir.
the first thing you do is to confirm that hearing loss. That is this true that you have hearing loss, and is it one that? And then go on to elaborating the presenting complaint, and then moving on to the history. And you, Tariq Khan asked you about the vision, which you kind of you missed out because you didn't then do in the history the systems and the cranial nerves. ये
Right,
तो
sir.
तुम जब patient सामने होता है तो हमेशा करते हो यार, and that's
सही
part
sir.
of the history, na? That's not part of the examination. So the way you do it, when the patient is in front, you try and think along those steps. Think along presenting complaint, discussing the presenting complaint, family history, and then system review. इस तरह करोगे तो बेहतर है. And I always try and say that मैं आपके सवालात आपके जिस्म के बारे में, आपके हेयर के बारे में पूछूंगा, whatever. You make that clear. ठीक है ना?
Right, sir.
So what Rashid is, Rashid Juma Sahab is saying that in your mind you should have made up लेनी है, उसको उसी तरह आप आगे लेके जाएंगे. So I think that will be, but quite good. I think you did quite well in the way you asked. So now Masood Saab, would you like to say something there?
जी, आई थिंक जिस तरह मुमताज ने प्रेजेंट किया है और जिस तरह रशीद जुम्मा साहब बता रहे हैं, आई थिंक ही हैज प्रिपेयर्ड क्वाइट वेल एंड ही डिड क्वाइट कॉम्प्रिहेंसिव हिस्ट्री, एंड इफ ही जस्ट लिसन टू डॉक्टर जुम्मा's advice, then of course he will be more better. लेकिन अभी की जो इसकी परफॉर्मेंस है, आई थिंक ही कवर्ड एवरीथिंग.
Good. So now you will move to the examination part of it. You're going to tell us how you're going to proceed with the examination.
On the targeted examination, first of all, in the general physical examination, I will target the inspection of the face, like see if there is any asymmetry of the face, or there is any one eye is opened. Then, sir, I will go to the cranial nerve examination. In the cranial nerve examination, I will examine for the second cranial nerve to see the visual acuity and the fundoscopy, and do the extraocular movement. And extraocular movement, I will judge for the nystagmus and the diplopia. Then I will see the corneal reflexor. Then I will see the sensation of the face bilaterally in the ophthalmic maxillary mandibular division. Then I will see the motor component and jaw jerk. Then, sir, I will see the facial nerve examination for the forehead and eyes and the nasolabial folds and the mouth. Then, sir, I will examine the ear cavity for inspection, then whisper test, and then I will examine the...
Can I stop you here, Mumtaz?
Yes, sir. Yes, sir.
So, can you explain to us the difference between upper motor neuron weakness and lower motor neuron weakness, facial weakness?
Yes, sir. In the upper motor neuron weakness, there is the contralateral loss of contralateral facial muscles are involved. Whereas in the lower motor neuron, the ipsilateral half of the facial muscles are involved. The reason is that the lesion is above the nucleus in the supranuclear upper motor neuron, and the lesion is below the facial nucleus in the lower motor neuron. Okay.
Upper motor neuron, can he close his eyes? Can he follow?
Yes, sir. Yes, sir. Only the smile is affected in the upper motor neuron.
So that's the major difference, right?
Right, sir.
That in the lower motor neuron, Both are affected, right?
Right, sir.
So you need to be very clear about what upper motor and lower motor neuron is, and you must tell us that how can you differentiate between upper if you are asked. Ji.
Yes. Then, sir, I will check for the Weber test and Rennie's test. In Rennie's test, I will get the air conduction greater than the bone conduction. In Weber test, the test will be lateralized towards the left ear. And then, sir, I will check for mouth for the uvula, do the cuff for to see the any change in voice, gag reflex, and size of the tongue muscle, and any fasciculation, and then deviation of the tongue on protrusion, and check the sternocleidomastoid muscle and trapezius muscle. Then, sir, I will check the for the cerebellar examination. Nystagmus I already checked. Then I will do the scanning speech and check the tone, finger nose test, dysdiadochokinesia, gait, pendular knee jerk, heel shin test, and I also check the pronator drift and the planters.
Okay.
And sir, I will also check the skin if there is any in the systemic examination, if there is any subcutaneous nodule present or caffeolous parts.
मुमताज तुमने पेशेंट का ब्लड प्रेशर नहीं लिया यार?
Yes, sir.
नहीं, yes sir क्या? नहीं, targeted वो अपनी जगह, but point really is that when you start off your examination, there are certain things that you always do, na? Whatever this thing is, nahi?
Right, sir.
So you check the patient for the basic systemic things that you always do, which is you look at the nails for anemia. Just that you look at it, and then you look to see what the pressure is, and you also do the vital, the respiratory rate, the pulse rate, respiratory rate. So वो तो will targeted ho ya na ho, those things are absolutely essential, because I mean, if that's in some way compromised and you're then having to deal with the patient, that makes a huge difference, nahi?
Right, sir.
On how you're going to manage the patient subsequently. Right, so I would really, for every, it's just this scenario, it's just a sentence. It's just a sentence. I would say that I would check the patient for vital signs, plus try and make sure that he was not anemic or in any way discolored or whatever. And that is the time that I would probably also look for cafe au lait. And then I'd move to my target. Nahin?
Right.
Tariq?
Yes. So you can say do a general physical examination.
Okay, sir.
Yeah. So that was just one sentence. So anything you have missed in the Juma Saab, has he missed anything in the examination? I think not.
Mumtaz, ये बताओगे Rennie's test, how you will do the Rennie's test and what kind of tuning fork you will use? Mumtaz, can you hear me?
Mumtaz, Masood साहब की आवाज आ रही है आपको?
Mumtaz गायब हो गया सर.
I think it's frozen here. So, Tariq Khan, this is going to be a real issue about connectivity, huh?
So there's going to be maybe one odd examiner who's going to be on Skype. All the other examiners, as far as I know, are going to be on site.
Achha ji.
Yeah. So we'll be physically present there. Some of these students are in Islamabad and some are in Karachi.
So they're going to actually be in the building?
In the building, yes.
Oh, so you're actually calling them?
Yeah.
But the interaction is via electronic, by
No, I don't think so. And जहाँ तक मुझे पता है अभी तक, we have been called to the center, and as far as I know, the students are not there also, unless they haven't mentioned that to us. ये students यहाँ हैं, तो पता होगा. आपको बुलाया गया इम्तिहान के लिए सर?
सर जल्दी
लाल
करो।
साहब,
जी सर, ये आ गया बस। अब ऐसा हमारे
नहीं, लाल वो नहीं, तारिक साहब कुछ और पूछ रहे हैं।
जी सर।
Are the students also coming to the center for the exam? Am I correct?
Yes sir, students को पता है।
जी सर।
Yes sir, yes.
They all are going to be there.
Yes sir.
जी सर, मेल भी हमें यही आई है कि we will be coming to the center.
अच्छा, वो गायब हो गए हैं, हमारे स्टूडेंट गायब हो गए हैं।
ये सर आ गया, ये सर आ गया, इधर बुला लिया, दूसरे कमरे में हमने उसके पास बुला लिया।
So Dr. Masood asked, what is the Rennie's test? How do you perform it, and what sort of a tuning fork do you use?
In Rennie's test, sir, I will place the 512 Hz tuning fork in the mastoid, first on the external ear, and ask the patient, can he hear? Then I will place on the mastoid bone. I will ask which is better, whether is the sound at the external ear is better or at the mastoid ear is better. This is the Rennie's test. And in the sensory neural deafness, the air conduction will be greater than the bone conduction.
और ट्यूनिंग फोक का क्या बता रहे हो?
512 Hz tuning fork.
हाँ?
512.
मसूद सुन लिया तुमने? 512 कह रहा है
जी।
या
Okay, so we move on now. कुमार साहब, आप आगे लेके जाएं इनको मैनेजमेंट प्लान पे, इन्वेस्टिगेशन पे या प्रॉबल डायग्नोसिस पे।
तो Masood, what specific investigation are you going to advise this patient?
Sir, I will advise for the audiometrics, sir.
Yeah, good.
And then, sir, I will ask for the MRI brain with contrast. And sir, then I will ask for the CT scan temporal bone.
Okay.
So can you tell us what is in your mind? What do you think is wrong with this patient who is presented with a progressive hearing loss in the right ear, and you found that he has got some poor balance?
There, I think so there is the lesion at the right CP angle that is causing the pressure on 8th cranial nerve and also on the cerebellar hemisphere.
So accordingly, you are going to ask for these investigations which you have mentioned, that you will do a
yes, sir. Yes,
audiometry, and then you will do a MRI brain. And why would you do a CT scan?
CT scan temporal bone, sir. I will see the anatomy of the temporal bone for the planning of the surgery. To see the thickness over the geniculate ganglion, to see thickness over the semicircular canal, and where is the jugular bulb is, and to see the position of the sigmoid sinus.
And why do you want to do all that?
To plan for the surgical treatment. If I am tumor is small and laterally placed, and I am planning the subtemporal approach, then I must know the bony thickness over the geniculate ganglion. If, sir, I am planning patient has total hearing loss and I am planning the retrolabyrinthine approach, then I have to see whether there is space that I can do the surgery retrolabyrinthine. So I will see the position of the sigmoid sinus, that whether it is anterior placed or jugular bulb is high, and so if that occur, then it means the space is tight. I cannot do the retrolabyrinthine approach.
Can you show some pictures? Investigations we have done.
So Tariq Khan, can I just stop you for a minute? Yeah. Tariq Khan, when we sit together in JPMC, I'm always telling these guys, please don't say anything more than you have to. And try in this scenario to don't say anything more than you've seen. And I want to ask you, as somebody who may be judging Mumtaz, what do you think about all this talk about the bone density of the geniculate ganglion and the middle fossa approach and so on and so forth? I mean, ये अपने आप को फंसा नहीं रहा, ये तो फंसा रहा है अपने आप को.
He's digging a grave for himself.
I mean, you know, Mumtaz, totally वो अपने आप को फंसा रहे हो. Because let me tell you one thing. The middle fossa approach, what you're talking about, is something that only happens when you have an intracanalicular tumor. Right. And these are small tumors, not what you said कि जो उसको ये था और उसको ये टैक्स दिया और उसको ये ऐसी कोई. दूसरा अगर तुमने कोई बात करनी भी थी कि मैं CT scan करा रहा हूँ, the real reason would have been to say that I want to be able to study the internal acoustic meatus की bony anatomy, which is also not true because वो MRI पे नजर आती है. And quite frankly, more important, the real reason that you want to do imaging to look at this thing is to see what is the distance between the meatus and the posterior semicircular canal, because अगर उसको तुम drill करके खोलने वाले हो, you want to stay away from that. तो वो देखने के लिए अब ये एक छोटा से काम के लिए तुमने इतना अपने आप को फंसा दिया है, and you've given the examiner, if the examiner doesn't like your face, you've given him an opportunity to just kind of bury you. So don't just only talk about the things that you've seen, please.
Right. You were lucky it was me. So yes, Juma Sahab is very, very right. You must stay focused and say what you normally do. Things which you don't do, you can, if somebody asks you, then you can say, yes, we could do this.
Sir, इसकी investigation दिखाएं आप लोगों को? Investigation हम दिखाएं सर आप लोगों को?
पहले ये क्या investigation क्या कराएंगे? Just name the investigation, Mumtaz.
The audiogram, sir, and MRI brain with contrast.
Okay. ठीक है, दिखा दें सर. अच्छा, ये तो आपकी फाइंडिंग्स हो गई. चलिए जी मुमताज साहब.
So this is the CT scan brain plane axial view showing the isodense area that is on the right CP angle and measuring approximately 4 into 4 in centimeter in size, and also compressing the fourth ventricle.
Okay. कोई और CT भी है लाल साहब या यही है खाली? Okay, Mumtaz साहब.
So this is a CT scan brain plane axial view and showing the ventricles, lateral ventricles, and sulci and gyri are open, sir.
Okay. ठीक है, पुराने वाला लगा दें, पिछले वाला CT लगा दें. क्या लग रहा है? हाँ, क्या लग रहा है फिर मुमताज साहब आपको?
Sir, this could be the meningioma, schwannoma.
Okay. ठीक है जी, MRI लगा दीजिए.
और कट्स भी दिखाते हैं ये MRI.
जी मुमताज साहब बताइए.
MRI post contrast image, even post contrast.
May I request everybody else to turn off their mics because there is a lot of disturbance.
This is a MRI brain axial view T1 post contrast showing the homogeneous contrast enhancement, and tumor is looking centered on the internal auditory canal, and the 7th and 8th cranial nerves are not separately visualized, And so there's also compression on the fourth ventricle and brainstem.
So, जी जी तारिक साहब,
What do you think this lesion is? Mumtaz?
Yes, sir. This is a number one is the vestibular schwannoma, and number second is the meningioma. Sir.
Why do you say it's a meningioma?
So because there is homogeneous contrast enhancement. Otherwise, there is no basal, broad base or dual tail sign are not present.
So he's got a hearing loss.
Yes, sir. The top
Um,
is the vestibular schwannoma. Sir. Second number.
There's no dual tail, right? And what about the
Yes.
internal auditory meatus?
So, it is arising from the internal auditory meatus. So there will be the enlarge in size the internal auditory meatus, trumpeting.
So can we say it can't be anything else other than yeah?
Vestibular schwannoma.
So I'm just wondering, why are you saying meningioma? What is there other than you say this is homogeneous enhancement? Is that right?
Right.
Mumtaz, you understood what Tarak Khan is saying now, because
Yes.
this is not the
Yes, sir.
first. This is not the first time you said meningioma. In the last 10 minutes, you said meningioma 3 times.
Right.
And the fact of the matter is that I want to ask you to tell me दो बातें हुई हैं, meningioma and vestibular schwannoma. मुझे तो परसेंटेज में प्रोबेबिलिटी दो. प्रोबेबिलिटी इस ए पहले की कितनी है और दूसरे की कितनी है, ये बताओ.
Vestibular schwannoma is 80% in the CP angle tumor.
80%.
And meningioma is 10. Yes, sir. And 10% meningioma.
तो 90% 10%.
जी सर.
तो फिर तुम यार meningioma की बातें 3 दफा क्यों की तुमने यार? That's what Tarak Khan is saying. When you first gave the differential diagnosis, you first said meningioma, and then after that you repeated it. So because this is pretty clearly not only that, you know, जब meningioma होता है ना, तो meningioma का ये है कि the hearing loss is never really until it's much later or only sometime. It's never really a prominent feature. They basically have pain, they have CP angle symptoms, and the hearing loss is a plus minus. Your patient presented with a hearing loss.
Hearing loss.
वो तो meningioma की possibility बहुत कम है यार. So I mean, if he's asking you कि जरा बताओ और क्या हो सकता है, then you say, yeah, it could be a meningioma that has grown towards the meatus. That's a possibility, but the probability is very low.
If you are asked without showing you the MRI, what are the lesions in the CP angle, of course, then you will tell us all what you know in the CP angle.
Right.
When you see this scan, then you know what else? Yeah, maybe, but not probable. You know, so that should make it very simple. Susa, would you like to say something?
नहीं ठीक है, इन्होंने बाकी चीजें तो कवर की हैं.
अच्छा, what will we do? अब क्या करेंगे?
How you'll proceed further?
So I will see the PTA, the how's the much the grade is. Then size of the tumor is greater than 4 centimeter. So I will go for the retrosigmoid approach. So, like before this, I will also counsel the patient and do the optimization of the patient and do pre-op workups.
What counseling would you like to do?
So first of all, I will ask the patient what does he know about his illness. Then I will educate him regarding the disease and then I will tell him the surgical, that I will do the surgery behind the ear, and then the possible complication of the surgery, and also tell him the hearing loss or the facial nerve loss according to his pre-op grading, that the what the risk is there post-operative, sir, and also the risk other of the other complications like meningitis, CSF leak, and the brainstem infarction, pica injury, uh, and then I will take the consent of the patient.
तो मुमताज ये बताओ, so what if he says to you कि डॉक्टर साहब मुझे ये लेजर के बारे में मैंने सुना है, उसके बारे में बताएं मुझे आप.
So the stereotactic radiosurgery, it is usually done on in the tumor less than 3 centimeter. So this tumor is large. So if we go for stereotactic radiosurgery, the symptoms will persist for the some duration, because the effect of the stereotactic radiosurgery take times 1 to 3 years. Otherwise, the outcome of the stereotactic surgery is good. The chances of the facial nerve preservation is 97% in the stereotactic radiosurgery.
Oh, but would you recommend to him, if he asks you, would you say yes, you
No,
can
sir,
do
I
it?
would not. I would not recommend it, because the size of the tumor is large, greater than 3 centimeter.
Is there possibility of hybrid approach?
And there is also mass effect, and there is also mass effect compression on the post-ventricle.
No, but what if the thing says to him, he wants कि जी आप मुझे कोई ऐसा तरीका बताएं कि ये सारे आपने रिस्क जो बताएं, फेशियल नर्व, मेनिंजाइटिस, ब्रेनस्टेम इंजरी, इसका रिस्क कम हो, तो वो कैसे होगा?
So, I will do the retrosigmoid surgery.
No, but is there any room for trying to reduce the risks that your
I will again do the neuro monitoring for these complications.
अच्छा नहीं मुमताज सर जो पूछ रहे हैं ये कि अच्छा तुम इसको मैं दूसरी तरह से पूछता हूँ, अगर तुम रेट्रोसिग्मॉइड अप्रोच कर रहे हो तो कितना निकालोगे ट्यूमर?
सर सबटोटल रिसेक्शन करेंगे, इंटरनल डिबल्किंग से.
इंटरनल डिबल्किंग फिर क्या करोगे?
फिर सर पोस्ट ऑप रेडिएशंस.
कौन सी रेडिएशन?
जी सर,
कौन सी रेडिएशन? होल ब्रेन रेडिएशन क्या?
होल ब्रेन रेडिएशन.
अच्छा.
So basically, Juma Sahab was saying, and what Masood Sahab is saying, that if you do internal decompression of this tumor, which will lessen the chances of all the most of the complications which you have said, and then give him this targeted radiotherapy using gamma knife or cyber knife or whatever, stereotactic would be a option which you can discuss with that patient.
सर इसमें काफी टाइम हो गए, तो should we proceed to the next case सर?
Please do.
तो इसमें सर इसको फीडबैक दे दे कि आप पास हो गए इस केस में, क्या हिसाब है इसका? इसको अभी रिजल्ट सुनाए सर इस केस में.
You know, to be very honest, I would pass him, because you know by now he knew what he was saying. ये जो हमारे स्टूडेंट्स का एक प्रॉब्लम है कि वो जैसे जुमा साहब ने भी पॉइंट आउट किया कि जो खामखा अपने आप को फंसाने वाली चीजें अगर वो ना बताएं तो यू नो इट इज बेटर, यू नो वो बताएं जो कि व्हाट दे डू रूटीनली इन देयर डिपार्टमेंट एंड नॉट व्हाट दे हैव रेड इन द बुक्स. If then the examiner is asking for more, then of course they can add their knowledge to that. Juma Sahab, what do you think?
Yeah, I agree, Tariq Khan. Thank you. I agree with you that Mumtaz, you're fine. You just need to just be a little bit organized in your own mind on how far you. As I keep saying, it's a compromise. It's a compromise between pleasing or fulfilling the needs of the examiner and exposing yourself to hazard. It's a compromise. So one always has to be careful about that.
Right, sir.
Okay.
Thank you, sir.
सर
Masood?
मसूद
जी
साहब
जी
आपने
जी
अपने ऑब्जर्वेशंस बताएं.
I think I agree with both my senior colleagues. History अच्छी थी, एग्जामिनेशन में सारी चीजें इसने कवर की हैं, and of course there was few things missing in the question answer, but I think he will pass. Like this case, if we
May
get.
I say something for the people who are listening? There's a question that already 20 minutes are passed and we are afraid that how will the exam finish in 60 minutes. The exam, don't worry, will finish in 60 minutes because the examiner knows how to guide you forward. वैसे पहले भी तो लॉन्ग केस के सामने होते थे तो वो एग्जामिनर आपको गाइड करता था और आपको टाइम पे सारा पूरा कराता था. ऐसे नहीं होता था कि बीच में रह जाता. So don't worry about that. This is just बहुत 20 minutes कोशिश कर रहे हैं प्लस थोड़ा बहुत फीडबैक साथ साथ देते जाएं so that you all understand कि भाई where are the pitfalls and how you going about it. So we'll move to the next.
थैंक यू सर. अच्छा, नेक्स्ट केस सर हम शुरू कर रहे हैं. द कैंडिडेट इज डॉक्टर सुधीर आलम. ही इज फ्रॉम एबटाबाद अयूब मेडिकल कॉम्प्लेक्स. वो करना चाहता है सर, तो ही विल डू इट. शुड वी स्टार्ट? और डॉक्टर सुधीर आप हैं?
जी सर, अस्सलाम वालेकुम सर.
वालेकुम सलाम. ठीक है, तो वी आर गोइंग टू स्टार्ट द नेक्स्ट केस. बताएं.
So this is the scenario for you. 45-year-old female patient presented to us with backache for 1 year and progressive lower limb weakness for 3 months. So do you understand the scenario?
यस.
ओके, ओवर टू यू सर. आपने ये सारा देख लिया अभी ना, तो आपको अभी गाइडेंस की जरूरत नहीं है. इन्हें किस तरह अपने पूछना है और किस तरह एग्जामिन करना होगा. तो यू आर इन फ्रंट ऑफ द एग्जामिनर्स. अभी आप शुरू कर लें, आपका टाइम शुरू हो गया.
जी सर. Sir, first I will introduce myself, and after taking permission from the patient, I will start my history from patient's biodata, sir. Then I will jump to the chief complaints, which in this particular patient includes backache for 1 year and progressive lower limb weakness for 3 months. First, sir, I will elaborate about the backache site, character, radiation, aggravating factors, relieving factors, as well as about the timing of the backache. Particularly, sir, whether this backache is present during night, during day or night. I will ask about the backache. Then I will ask about the, sir, any trauma, sir, any drug abuse, as well as sir, any spinal procedure which has occurred before. After completing my backache history, sir, I will take history of weakness, sir, whether this weakness is a gradual or gradual or acute, sir, whether it is progressive or acute. After completing my chief complaint, sir, I will jump to the higher mental functions as well as cranial nerves, sir, and then I will take a midline history, sir, for the completion, just for the sake of completion of the history, sir. After that, sir, I will take past history, family history, personal history, as well as any drug history. Then I will do systemic inquiry, sir, like weight loss, sir, any fever, sir, and in backache, sir, I will ask about as well as about the site of backache. I will ask about as well as site of the backache, sir. That will be my history, sir.
अच्छा, हिस्ट्री में आपने जो है वीकनेस से क्लियर से क्या क्या पूछा था, दोबारा बताइए.
सर, वेदर इज ए प्रोग्रेसिव. आई मीन इनिशियली इट वाज.
ठीक है, ओके.
दूसरा सर मैंने पूछा था कि ट्रॉमा का इसमें मैं पूछूंगा सर.
अच्छा, बाउल और ब्लैडर के बारे में पूछा आपने?
सर पावर और ब्लैडर, सॉरी सर, ब्लैडर के बारे में नहीं पूछा है, बाकी पावर का सर.
नहीं, बाउल और ब्लैडर.
बाउल और ब्लैडर कह रहे हैं वो, बाउल और ब्लैडर कह रहे हैं.
जी सर, उनका नहीं पूछा था सर.
ठीक है.
आपने मसूद, सॉरी, आपने बाउल ब्लैडर का आपने मुझे ये बताया कि आपने ये उनसे पूछा कि द पेन आपने टाइम का तो पूछा, बट रिलेटेड टू रिकम्बेंसी, लेटने से कोई आराम आता है, चलने से ज्यादा होता है, कुछ ऐसी कोई बात है?
Yes, sir. I should ask definitely, sir.
You should ask definitely, right?
जी सर, जी सर.
अच्छा, हिस्ट्री से कोई आप बता सकते हैं कि कितनी पावर है इसको?
पावर तो सर पेशेंट नहीं देखा है मैंने तो सर.
नहीं वही कह रहा हूँ ना,
डिक्रीज
अगर
पावर है
देखें
सर. जी
अभी
सर.
आजकल तो देखें
जी
आप
सर.
इंटरनेशनली जो है हर जगह टेली क्लिनिक्स हो रही हैं, तो आप
जी सर.
पेशेंट से पूछ सकते हैं कि कितनी पावर है, कैसे पता लगा सकते हैं कुछ?
जी सर, मैं उससे पूछूंगा कि सर चल सकते हैं कि नहीं चल सकते हैं. अगर उसमें मुझे आइडिया हो सकता है. दूसरा सर मैं उसको ये पूछूंगा कि लेटे भी कोई टांग ऊपर उठा सकते हैं कि नहीं उठा सकते हैं सर.
आपने
उससे मुझे
पूछा था
आइडिया
इससे?
हो जाएगा सर.
पूछा
इससे
था
नहीं
आपने या
पूछा
नहीं?
सर.
अच्छा
नहीं सर,
ठीक,
इससे नहीं पूछा. जी सर, जी सर.
ठीक है, ठीक है, चलिए ओके,
इसकी
चलिए
फैमिली
आगे
के
बढ़िए.
बारे में, फैमिली के बारे में कुछ क्या पूछेंगे आप?
Sir, family history in this particular question, I will ask about diabetes mellitus, sir.
What about exposure to tuberculosis?
Yes, sir, I will ask about tuberculosis as well as diabetes mellitus. And any other hypertension, sir, any disease in the family, I will ask.
क्या डिजीज और कोई डिजीज पर्टिकुलरली इस पेशेंट के लिए ऐसे पूछेंगे आप? तो
Sir,
डायग्नोसिस में हेल्प कर सके.
immunocompromised, जी सर, immunocompromised disease के बारे में मैं पूछूंगा. Any drug, particularly सर steroids वगैरह के बारे में मैं पूछूंगा.
अच्छा, ट्यूमर
जी
के
सर.
हवाले से कोई चीज पूछ सकते हैं?
सर फैमिली हिस्ट्री में भी मैं पूछ सकता हूँ. और इसके अलावा सर मैं इस पेशेंट से भी पहले कोई सर्जरी का, जिस तरह मैंने बताया, आई हैव ऑलरेडी टोल्ड सर, आई विल आस्क अबाउट एनी पास्ट सिग्निफिकेंट मेडिकल हिस्ट्री एज वेल एज सर्जिकल हिस्ट्री रिलेटेड टू द पेशेंट, सर आई विल आस्क.
अच्छा ठीक
जी
है,
सर.
तारिक खान साहब आप
तारिक खान, microphone.
सर क्या आवाज?
So did you ask him how his legs are feeling? Did you ask him about the sensation?
सर सेंसेशन का नहीं पूछा है.
Okay, so you need to be very careful. You need to अगर आप ये कहेंगे ये पूछना था, ये भी पूछना था, ये भी पूछना था, ये भी पूछना था,
जी सर.
तो फिर ऐसा हो, make it very simple कि कितने जवाब एग्जामिनर देते हैं और कितने जवाब आप देते हो. अगर आप ज्यादा जवाब देते हो तो then you are moving forward.
जी
You
सर.
understand? So you need
I understand,
to
sir.
be very careful. So
जी
now we
सर.
move forward on your examination. What type of examination would you like?
Sir, after taking questions, sir, I will do GPE, sir, general physical examination, which includes blood pressure, pulse, lymph nodes, respiratory rate, sir. And then I will jump to the lower limb, sir. Initially, I will inspect for any scar, any marks. Then I will do, sir, palpation of pulses, which includes pedal pulses as well as popliteal pulses,
डॉक्टर
sir.
साहब ये
Then I
स्कार
will
किधर
do,
देखे
sir,
आपने? ये
सर स्कार सर एक तो मैं लेग्स में देखूंगा सर, दूसरा उसकी फिर एक्सटेंशन करके बैक में भी देख लूंगा सर.
अच्छा ठीक है.
जी सर, जी सर. सर देन आई विल चेक टोन ऑफ द पेशेंट with the power and reflexes as well as planters. Then I will jump to the sensory system, sir, including sir sensory level, joint position, temperature, pain, extra, sir. Then I will check for the bladder, sir, and I will inspect the back of the patient for any scar, as I have already told, sir, for any tenderness, sir, and for any visible things which I can see on the back, sir. After completing my lower limb examination, sir, I will go for upper limb to check the upper limb examination, sir, which includes again tone, power, sensations, reflexes, as well as power, sir. And then I will, sir, complete my rest of examination, including cranial nerves and, sir, higher mental functions.
क्या आपने
जी सर।
क्लोनस चेक किया था?
सर रिफ्लेक्सेस मैं चेक करूंगा तो मुझे
वो तो हो जाएगा, लेकिन सवाल, एक सवाल तो ये है कि आपको आइडिया
जी
लगाना है,
सर।
जो कि आप पूरी लाइफ में अपने यही
जी
करेंगे।
सर।
लेकिन इस पर्टिकुलर मूवमेंट में एक और भी काम है आपका,
जी
कि
सर।
एग्जामिनर को पता है कि आप क्या क्या कर रहे हैं,
जी
और
सर।
अगर आप नहीं बोलेंगे
जी सर।
तो हमारी जो नोटबुक है उसमें हम लिख लेंगे कि
जी
आपने नहीं
सर।
किया है। तो क्लोनस आपने किया या नहीं किया?
क्लोनस मैंने चेक नहीं किया सर।
पोजीशन चेक किया आपने या नहीं की?
जी सर, वो मैंने जॉइंट पोजीशन और वो मैंने बताया था सर। जी सर।
बताया था आपने, अच्छा ठीक
जी
है।
सर।
तो ये बताइए कि ये L3 सेंसेशन कहाँ पे चेक करेंगे आप?
सर L3 सेंसेशन नी के मीडियल साइड पे चेक कर लेंगे सर।
और L5 की मोटर पावर कहाँ पे चेक करेंगे?
सर L5 की मोटर पावर सर फुट के डोर्सिफ्लेक्शन चेक करेंगे सर।
और L4 की?
L4 की पावर सर
जी,
वो भी सर डोर्सिफ्लेक्शन
किसमें?
चेक करेंगे
L4
सर।
में?
जी सर।
श्योर?
सर ये दोनों मिक्स होते हैं, लेकिन L4 के लिए पार्टिकुलरली बिग टॉप का जो है वो डोर्सिफ्लेक्शन चेक करेंगे सर। इसके साथ
अच्छा,
हम मैं
चेक कर लीजिएगा बाद में, एग्जाम के बाद जाके।
अच्छा
चलें,
जी
ठीक
सर।
है। डॉक्टर
अच्छा सुधीर साहब,
साहब आप कुछ
सुधीर साहब, आपको यू आर चेकिंग फॉर टेंडरनेस, so how can tenderness help you in your diagnosis?
ऑन पाल्पेशन सर।
नहीं, टेंडरनेस आप
जी जी
देख रहे थे तो किस तरह आप देख रहे थे, और व्हाई यू आर डूइंग दैट?
In the back sir, in the cases like sir osteomyelitis or any abscess sir, the spine will be tender sir on the back sir.
ठीक है सर, आप लोग पूछ रहे हो क्वेश्चन पूछ रहे हैं।
तो डॉक्टर साहब, ये केस आपको लग क्या रहा है?
Sir, according to the history sir, this is the most likely sir any space occupying lesions are sir in the back sir, and it can be sir any degenerative pathology, and it's less likely that sir it can be a infective pathology or inflammatory pathology.
Lal, can we see the examination slide?
Yes sir, yes sir.
So this is your examination.
जी sir.
So what does it say, that where is it?
So these are the findings for you. This is power 3/5, and there is no tenderness over the spine.
There is no tenderness. अच्छा,
ठीक है सर, ठीक है सर। ये ऑलमोस्ट सर ये D6 D5 D6 लेवल पे मोस्ट प्रोबेबली लीजन सर।
And what sort of lesions do you know?
Sir, in dorsal spine sir, it can be any case occupying lesion sir, tumors including sir meningioma, schwannoma, astrocytoma, ependymoma. It can be metastatic. On second number sir, it can be a degenerative disc sir, as well as spinal stenosis in this level sir.
Would you like to divide it into extradural, intradural, intermedullary, extramedullary? Would that be better?
Yes sir, extradurally sir, the most common space occupying lesion is sir metastasis with sir synovial cyst, and sir इसके अलावा सर meningioma भी extradural हो सकता है, लेकिन बहुत less likely है सर। Intradurally जो है सर meningioma होगा, schwannoma होगा सर, and intramedullary will be ependymoma and astrocytoma sir.
In this patient with a history of 1 year, you think it could be metastatic?
सर मेटास्टेटिक लेस लाइकली है सर।
आपने सबसे पहले मेटास्टेटिक बोल दिया।
सर आई वाज talking about extradural most common lesion sir.
इस वक्त we are talking about this particular patient.
जी सर, जी सर।
Sensory level at D7, power of 3/5, and a gradual
जी सर।
1 year and gradual deterioration of the lower limbs. So
जी
we
सर।
stick.
सर एक्स्ट्राड्यूरल फिर मोस्ट लाइकली सर न्यूरोफाइब्रोमा हो सकता है सर इन दिस पार्टिकुलर केस या schwannoma सर.
नहीं, extradural, intradural.
Extradural sir, schwannoma or neurofibroma sir, it can be both intradural as well as extradural. Intradural sir will be meningioma, schwannoma, neurofibroma sir.
And then you said intramedullary also.
Intramedullary sir, astrocytoma, ependymoma, then astrocytoma sir.
With your experience, what would come on top of the list of a patient like this? आपने काफी देखे होंगे, आपने
जी सर.
What would come on top of the list here? He's a male, right?
जी सर, जी सर.
Female. She's female.
Female. Sir, top sir meningioma and उसके बाद sir schwannoma, फिर ependymoma sir.
So you think with this graduate history, most likely it will be an intradural meningioma, right?
जी sir.
So what investigations would you like to get for this?
Sir, after baseline investigation, I will go for radiology, sir. For this particular case, sir, MRI dorsal spine with and without contrast will be the gold standard, sir. But we will do X-ray dorsal spine as well as a CT scan dorsal spine, sir, along with the MRI dorsal spine with the contrast.
Why?
Sir, in X-rays and CT scan, sir, we can guess about the bone of the particular area, sir.
How many patients with this history you have done an MRI and then you have done CT scan also? How many patients?
Sir, बहुत कम patients में ज़्यादातर MRI ही कराते हैं, sir.
क्यों आप ऐसे? You do a plain X-ray and you do an MRI, right?
जी sir.
This is what you would like to do?
Yes sir, definitely sir.
MRI, if you have one.
Yes sir.
Can we see the MRI?
Yes sir. ये MRI है sir. और ये उसकी दूसरी फिल्म है.
जी डॉक्टर साहब MRI पढ़ के बताइए हमें.
Sir, this is a sagittal MRI of the static patient, sir. Sir, which sir, sorry, मैं दूसरे cuts देख सकता हूँ sir MRI के.
ये आप पहले बता दें फिर दूसरे भी दिखा देंगे.
जो नजर आ रहा है आप इसको डिस्क्राइब कर लें, बाकी आप दिखाएंगे आपको.
जी sir. Sir, this is sagittal MRI of the previously stated patient T2 weighted images, sir, which shows sir lesion in the area of D5, D6, sir, which is hypointense, sir, in T2 weighted, sir. About size, sir, almost 3 and 2 centimeters, sir.
क्या कर रहा है ये cord के साथ कुछ हो रहा है?
Sir, compressing the cord, sir, and obliterating the CSF columns, sir, anteriorly completely, but posteriorly there is streak of CSF column present, sir.
अच्छा, तो और कौन सी आप कह रहे थे और इमेजेस चाहिए आपको? कौन सी इमेज चाहिए आपको?
सर एक्सियल हो और सर कंट्रास्ट के साथ भी हो तो सर.
फिलहाल साहब है कुछ आपके पास इस तरह का जो मांग रहे हैं?
ये तो
चलिए
है और ये एक्सियल कट.
चलिए आपको दोनों ही मिल गया आपको.
जी सर.
आप बताइए.
Sir, this lesion is taking a contrast, sir, homogeneously, and it is compressing the cord from the. It is basically arising from the left side and compressing the cord towards the left side, sir.
Towards the right side.
Towards the right side, yes, sir.
अच्छा, तो अब क्या आपकी डायग्नोसिस क्या बन रही है फिर?
Sir, my most likely diagnosis is sir meningioma, sir.
अच्छा, जुमा साहब आप कुछ पूछना चाहेंगे?
सर मुझे ये बताएं कि just to come back to what Tariq Khan classification was, पहले आप ये बताएं कि do you think that this is intradural or extradural?
Sir, this is intradural, sir.
Okay. And why do you say that?
Sir, because it looks in the canal, sir, and it is compressing the spinal cord matter, sir, as well as on.
Why? Sorry, Doctor, but I mean, why can't it be in the spinal canal but compressing the dura?
सर इसमें एक्सेल में सर CSF भी सर कार्ड उस सर सॉरी इसको तो आई डिडंट अंडरस्टैंड सर ये
नहीं मैं बड़ा सिंपल सवाल पूछ रहा हूँ आपसे
जी
कि
सर
आप ये कह रहे हो ना कि ये इंट्रास्पाइनल है, आई एग्री विथ यू, फिर आप कह रहे हो कि दिस इज कंप्रेसिंग द स्पाइनल कॉर्ड, आई एम सेइंग
जी सर
why is it not possible that this is compressing the dura because it's extradural but intraspinal?
Sir, in the sir axial weighted image, sir, which I have seen earlier, sir, in that particular image, sir, it is in the sir intradural, sir.
Oh, you've seen another image that you haven't seen. I see. That's interesting. Lal Sahab, what's going on?
नहीं
Doctor Sahab, what I was trying to bring you to was that you're absolutely right. It's most likely intradural, but to be absolutely sure, what you would request would be a coronal section, the coronal section of the MRI, which would give you greater confidence in saying कि नहीं सर ये नजर आ रहा है कि this is intradural or extradural.
जी सर.
If you saw the coronal section.
So coronal section हमारे पास नहीं है सर. Sorry.
Yeah, sure.
So what will you do now? Where will you go from here?
Sir, after counseling, I will admit the patient, sir. Then I will take detailed history as well as detailed examination, sir, and investigations from baseline to radiological investigation, sir. Then I will take pre-anesthesia clear, sir. After that, sir, I will go for surgery, sir.
What sort of surgery will you do?
Sir, should I tell surgical procedure steps, sir?
What are the requirements which will be there available with you if you're going to operate on this patient? ऐसे बता दें.
Sir, sorry, समझ नहीं आई, sir.
क्या equipment आपके पास होना चाहिए जिससे आपकी ये surgery will be much?
जी sir. Sir, ideally, along with the microscope, sir, ideally I should have, sir, QSA, sir, as well as a neurophysiologist with the somatosensory work potential as well as motor work potential, sir. If facility is available, sir, my instrument, there should be, sir, also ultrasound, sir, for intraoperative localization, sir.
Drop MRI. नेविगेशन
इसके अलावा सर न्यूरो नेविगेशन भी सर हम इसमें यूज कर सकते हैं.
मसूद साहब
ठीक है.
मसूद आप न्यूरो नेविगेशन इस्तेमाल करोगे इस केस में?
नहीं, न्यूरो नेविगेशन तो नहीं कहते, न्यूरो मॉनिटरिंग करते हैं.
नहीं अगर आपके पास न्यूरो नेविगेशन स्पाइनल हो भी
नहीं, if I have ultrasound that would be enough, particularly in this case which is posterior to the cord, so
right.
I don't see any additional advantage. ठीक है, मेरे ख्याल में तो इनका.
What complications are you looking at?
Sir, post-operative complications include, sir, deteriorating neurology due to injury to spinal cord as well as spinal nerve groups, sir. Post-operative there can be CSF leaks, sir. Post-operative there can be infections, sir, including osteomyelitis as well as abscess, sir. As well as there can be, sir, post-operative any type of epidural hematoma, sir.
Can we?
This is the most probable. Yes,
Can
sir.
we do the third case today, or these two will be enough? तीसरा केस भी हमारा तैयार है सर.
I have to beg leave, Lal. So if you want to carry on, you can. But I have to.
Lal,
beg
it's
leave.
up to you, यार. अगर आप करना चाहें तो, I mean, आपका कैंडिडेट अगर है, otherwise we can do it again.
कैंडिडेट सर तैयार हैं, लेकिन अगर आप लोग कहें तो वो हम 15-20 मिनट में कर सकते हैं.
ठीक है, मसूद.
जी ठीक है, I have time.
तो सर इस पे
Okay, Lal.
जी सर.
Lal, just by the way, this particular spinal tumor, it'd be good for hemilaminectomy, nahi?
Yes.
From the left side.
एक साइड पे ज्यादा. Yes, you're right.
Only on the left side.
Yes, yes, sir.
And you open the dura also on the left side, so you almost never see the cord. You only see the tumor.
Yes, sir. बिल्कुल. It will be better, and we can do it very easily through that way.
Yeah, absolutely, absolutely.
तो सर इसको आप लोग अपने जो फीडबैक दे दें ताकि हम पास किया फेल हो रहे क्या हिसाब है, ताकि हम तीसरा केस शुरू कर लें.
Yeah.
और सर तीसरे केस के मैं आप लोगों को इमेजेस भिजवा रहा हूँ, आप लोग व्हाट्सएप पे तो आप देख भी लीजिए.
Yeah, sure. Doctor साहब जो हैं वो Doctor साहब is jumping too much. Doctor साहब शुरू में हिस्ट्री लेते हुए he was jumping from this. Okay, I'll next jump to this and I'll next jump to that. और वो सही तरह जो बंदा आपको पूछ रहा है वो हिस्ट्री का आपको मौका दे रहा है. You have to show that you're somebody, you're not wanting to jump into. आपके पास already scan है, आपके पास already you know कि आपने उसको ऑपरेट करना है, and the whole impression is that you're jumping straight to the, operating on this patient. Whereas you needed to ask some the really important things जो पहले मसूद ने point out की bowel bladder की, and फिर जो तारिक खान ने point out की about sensation, मैंने आपको point out किया था about the associated cafe au lait spots or whatever have you, and तो मतलब मैंने कि you need to be a little thoughtful. Don't try to come to very quickly. Don't very quickly want to come to the end of the story. आप थोड़ा सा जरा,
yes, sir.
You know, just you have to impress the person with you. You're a thoughtful person and you try to think the things through.
Yes, sir.
And similarly on the examination, आप लोग मतलब my request to all the people who are listening and think, please in your mind go through and have your template, and then if they ask you about how are you going to ask the history, please then go through that checklist in your mind. And if they ask you how will you examine, then go through that checklist in your mind. And that way, you'll be proceeding in order. And secondly, you won't miss really important things. I can't believe, Dr. Saab, that you're obviously, you've obviously done quite a lot of neurosurgery training. I can't believe कि आप bowel and bladder पूछेंगे नहीं, मगर आप बोलना भूल गए because आपने checklist पे चले नहीं आप.
Yes, sir.
ठीक है.
Yes,
so,
sir.
Sorry, Tariq Khan, I don't know what you think, but I think Dr. Saab made some major omissions, and I would not be able to let him go.
Yeah, I totally agree, with Juma Saab. You need to work more, and I think, just Juma Saab keh rahe hain, we are quite sure that if you had a patient in front of you, you would have done all that and asked on that. But you need to make, as for everybody, again, to make a checklist in your mind. कि भाई हाँ मैं ये पूछूंगा, हाँ ये मैं examine करूंगा. So I think it's better. So you need to work more on this, Dr. Saab.
Yes, sir. Thank you.
Lal, next.
अच्छा सर, नेक्स्ट डॉक्टर तैमूर हैं. ही इज फ्रॉम फैसलाबाद एलाइड हॉस्पिटल से हैं, और ही विल बी द स्टूडेंट कैंडिडेट होगा. तो डॉक्टर तैमूर आप हैं?
जी सर. जी सर.
तो अभी आपको हम जरा सिनेरियो देते हैं और आपने पूछना है जो जिस तरह आपने.
The scenario for Dr. Taimur, 45-year-old male patient presented to us with headache for 1 year and decreased bilateral vision for 2 months. Okay.
जी ठीक हो गया.
You can read it again and then you have to start your history.
बाकी क्वेश्चन आपने पूछने हैं to reach your diagnosis.
बाकी लोग काइंडली अपना माइक जो है वो म्यूट रखें. Thank you.
Okay, first of all, I would like to. Okay, first of all, after greeting and introducing myself and taking the consent, I will take the biodata of the patient and then I'll start with my presenting complaint. The headache that is for 1 year, its site, its onset, its character, its radiation, how it gets worst with training or any other thing, or how it gets relieved, and its timing and its association with any vomiting or decreased vision. And then I will ask about my second presenting complaint about decreased vision, for how long it has been. It's in the one eye or both eye, either it's progressive or not, either there is color appreciation or not, and either he can see from the sides or only from the center, or he is having diplopia to double vision, and or any kind of hallucinations and visual obscurations that gets better with time. I need to clear that as well. And once I'm done with it, I will like to go with my systemic inquiry about his lobes, especially the frontal lobe signs, about his any change in personality or any other decreased mentation or incontinence, and other parietal, temporal, and occipital lobe I would like to rule out. Then I will ask the midline, try to rule out midline lesions like pituitary. Either a patient is having any increase in size of hand or foot, or any sudden onset of diabetes or hypertension, or patient is having any orthopnea or dyspnea, and either is there any lactation from the chest, or if he's a male, yeah, he's a male, then either is a loss of libido, and then heat or cold intolerance or striation on the body, or any localized obesity. And then my focus would be on the is there any sudden loss of consciousness, to rule out any ventricle extension. And then my cranial nerve on the history, like if olfaction is cleared and the patient can move his eyes all around, and is there sensation intact on all the on all aspects of his faces on face, and the rest of the cranial nerve examination, like any facial palsy or hearing issue, or any issue with the deglutition or swallowing or with speaking. And then rest, like with cerebellar, with any issue with his movement and walk and gait, and any tremor. And after that, I would like to ask about his medical history, like any issue with his any taking any medicine for blood pressure, sugar, or any tuberculosis, or any previous surgery he has had, or any family history of such kind of disease, and about his socioeconomic status. That's it.
ये मसूद साहब आप उनसे इधर
ठीक है। अच्छा, विजन के बारे में आपने पूछ लिया
जी सर।
तो विजन के बारे में आप कुछ अंदाजा लगा सकते हैं हिस्ट्री में कि जी टोटल ब्लाइंडनेस है कि कम है उससे?
जी सर।
वो कैसे पूछेंगे?
सर पेशेंट से हम पूछ सकते हैं कि पेशेंट को नजर आता है, कितने डिस्टेंस से नजर आता है, if he can see at a yard or at a foot, or if he can appreciate hand or hand movements or any light or no perception of light.
ठीक है, ठीक है। जुमा साहब, आप कुछ पूछना चाहेंगे सर?
So, Dr. Saab, in your history, you ask, when we take a history of headache, one of the things that we're always quite interested in is the localizing value of location. And then the localizing value of its occurrence in time, at time of the day. And then its association with vomiting. You didn't explore any of these avenues of questioning.
Yes, sir. I've asked him about its onset, its location, its time, its radiation, its association with vomiting.
Achha, I didn't hear that you specifically were interested in the location of the headache. Because आप मुझे बताएं कि what would typically be the location of this headache?
Sorry, sir?
What would typically be the location of this headache?
Sir, in this case, mostly there would be frontal headache in the patient. If what I'm thinking is it is.
Right. And now, what about the vision, the visual impairment?
Yes, sir. Sir, I've asked about the history questions about its onset, duration, its progression, its completeness, is it complete or not, its color association, and its sides or in the center, or diplopia association or not, any visual obscurations.
Yeah, I mean, Doc, what I'm trying to bring you to is that when you see somebody who has a visual impairment, you try to figure out by questioning and then later by examination whether it's just an acuity problem or whether it's only a field problem, or is it a acuity plus field problem. आप समझ रहे हो मेरी बात है? And that's what Dr. Masood was trying to ask you. Masood was trying to ask you कि आपने जो vision की impairment बात सुनी है, how will you try to figure out? How will you try to figure out whether it's a acuity problem, a field problem, or a combination of acuity and field?
Sir, on history, like I've asked the patient about, he can see on the sides. I mean, that can let me know either if there's a compressive lesion or not. Then I asked about double vision that can occur in the raised ICP as well as in the lesions that are extended to the cavernous sinus. And I also asked about visual obscurations, like that vision decrease and then it gets better. That also occurs in hydrocephalus. So these questions were actually, and the color vision, that also shows that there's any compression on the chiasm. So these questions were actually to rule out the lesions and the association of vision.
How does color vision
in it is a red green color. These get affected first, the primary colors.
And is that what is that a usually clinically helpful presentation? How many patients with pituitary adenoma compressing the chiasm and come and tell you that I'm fine except I can't see red?
No, I mean it's quite rare, sir. But just for the sake of completion, and also
no. I want to ask you. No, it may be rare, but I want to ask you: have you ever seen somebody with the pituitary adenoma who's come and said, "I can't see red"?
No, sir. I haven't seen it.
तो लाल साहब इस मौके पे आप कोई इनको बताते हैं फाइंडिंग्स या नहीं हिस्ट्री के बाद के जी ये चीजें पॉजिटिव या नेगेटिव हैं? हेलो, अच्छा नहीं, ये तो एग्जामिनेशन में है ना, हिस्ट्री में नहीं बताते हैं आपके जी, ताकि ही कैन प्रोसीड फर्दर विद दैट। आवाज नहीं आ रही आपकी?
I think he should ask for कि भाई इस पेशेंट में मैं ही पूछूंगा ये उसमें है कि नहीं है, तो इसमें ज्यादा क्लियर हो जाएगा ना।
अच्छा, चले आपकी हिस्ट्री में ये पता चला डॉक्टर साहब के इसको जो है ना कुछ फील्ड डिफेक्ट है, तो अब आप तो पहले ये बताएं कि जी आप क्या समझ रहे हैं लोग पैथोलॉजी वाइज, एंड देन प्रोसीड फॉर द एग्जामिनेशन।
Sir, if there's a field defect, then I will consider it there is a sellar or parasellar lesion, and then I would like to go with my examination, and starting with the general physical examination, and then the orientation and all the cortical signs. I will come to the cranial nerve examination, starting with olfaction, and then second cranial nerve with his near, far, and color vision, and then confrontation and fundus examination, and movement of his eyes in all the quadrants, and light and near reflex. And then I will proceed with my fifth nerve examination, checking his sensation in all the three divisions of trigeminal nerve, and then the corneal conjunctival reflex as well, and followed by the other cranial nerve examination like seventh, eighth, and so on. But my primary focus would be on the first and second and third, fourth, and fifth and sixth cranial nerve.
तो जो field examination करते हैं आप कैसे करते हैं फिर?
Sir, usually examination के अंदर तो we do by confrontation method. You sit at the level of the patient with one arm distance, and we close the same eye as the patient is closing. If he's closing his right eye, then I will close my left eye, and then I will check the field in all the vision in all the fields by bringing my.
क्या दिखा?
Sir, usually finger को move करते हुए different quadrants से लेके आते हैं. Either he can appreciate it or not.
अच्छा. अगर आपको इसको ट्रोमा और फील्ड डिफेक्ट में डिफरेंशिएट करना हो तो कोई चीज आप कर सकते हैं डिफरेंट, कोई कलर यूज कर सकते हैं जिससे ज्यादा पता चले बेहतर?
Sir, I'm not sure.
ठीक है, कोई बात नहीं. अच्छा, तो ये कर लिया आपने, और फिर अच्छा ठीक है आपने क्रेनियल नर्व कर ली, उसके बाद फिर आपके पास टाइम है अभी?
So rest I will complete my examination with the cerebellar examination, and then upper and lower limb examination complete.
अच्छा, आपने डायग्नोसिस क्या बनाई थी?
Sir, if the patient is having bitemporal hemianopia, like they have already shown, then it is a cellular lesion.
तो ठीक है, सेलुलर लीजन में तो मैं पूछूंगा आपसे, बहुत सारी चीजें हो सकती हैं. क्या इसको ग्रोथ हार्मोन का प्रॉब्लम हो सकता है?
सर वो हिस्ट्री पे इन्होंने मुझे बताया नहीं है कि यानी हैंड और कोई साइज इंक्रीज हुआ है उनका, एनी हाइपरटेंशन और डायबिटीज, ये थोड़ा सा मुझे इसमें हिस्ट्री में थोड़ा बता दें तो.
अच्छा, तो जनरल एग्जामिनेशन वैसे करते हैं आप या नहीं?
जी सर, जनरल एग्जामिनेशन में भी ये चीज पता चल जाएगी.
तो आपने यही किया था ना पहले, आप फर्स्ट क्लिनिक से अपने स्टार्ट किया था, किधर से किया था एग्जामिनेशन अपना?
सर मैंने पहले बोला था कि आई विल डू द जनरल फिजिकल एग्जामिनेशन एंड देन द.
ठीक चलो, डॉक्टर जुमा आप कुछ पूछना चाहें या लाल साहब?
अच्छा, तो बायोटेम्पोरल हेमियोनोपी है और बाकी ठीक है, कुछ फाइंडिंग नहीं है इसमें.
अब आपकी क्या डायग्नोसिस बन रही है?
हाँ, नहीं
जुमा साहब जी. जुमा
So डॉक्टर साहब जरा प्लीज, you were saying कि आप फिर in response to डॉक्टर मसूद क्वेश्चन कि आप उसका सेरेबेलर देखोगे, फिर उसका मोटर देखोगे, और क्या देखोगे?
सर अपर एंड लोअर लिम्ब एग्जामिनेशन जो है वो सारा कंप्लीट कर लूंगा.
और
सर बाकी मैंने कर लिया ऑलरेडी, जनरल फिजिकल एग्जामिनेशन, कॉर्टिकल साइंस, and then cranial nerve, his head, and then cerebellar up.
Yeah, cortical science में आप you were a little explicit, but आप general की जो बात कर रहे हो, you're not being explicit. मकसद कहने का ये है डॉक्टर साहब, you know, शुरू से you've kind of raced through your this thing, through your which is fine, but done it in a way that hasn't allowed you to explore what this problem is. What I'm trying, मैं आपको examination का ये कह रहा था कि ये इस case में, you particularly when you're examining, you want to be seeing first, and you need to mention the stigmata of hypopituitarism. कि आप देख रहे हो उसको, कि आप छाती के बाल देखोगे, हाथ के बाल देखोगे, टेस्टिकुलर साइज देखोगे, तो ये those things are a little this thing. And whenever you're dealing with somebody who has a bitemporal hemianopia or something that suggests a subfrontal lesion, the actual, I know you said gait. I know तुमने चलते चलते में gait को mention किया. I've heard that word from you. लेकिन specifically that I want to look at the gait to make sure that his Romberg is not altered and he can tandem walk in a straight line. मतलब that just gives the impression कि यार
Yes.
आप अपना examination भी जरा target करके focus करके आप findings निकाल रहे हो.
ठीक जी सर.
Lal, yeah, that's fine. I mean, we can.
Yes, sir. Now we should proceed, sir, to the further
Yeah.
management तरफ
Yeah.
हम जाएं.
Yeah, yeah.
So
ठीक है.
investigation.
How you will, आपकी क्या diagnosis है and how what investigation would you like to do?
Sir, my differentials are cellular supracellular lesion, like could be adenoma, craniopharyngioma, or an. So I would like to get and followed by MRI brain with contrast, and if it turns out to be a cellular lesion, then pituitary.
Can you repeat yourself? Can you repeat yourself? Sorry, Dr. Saab, I didn't hear the first bit. Repeat करें, क्या करेंगे आप?
So CT brain, first of all, I would like to get.
अच्छा, और MRI.
CT brain plane.
और MRI उसके बाद.
Dr. Saab, your vision, your sound is.
उसके बाद MRI brain with contrast. I will.
ठीक है. और
क्या investigation करना है?
आपकी आवाज ब्रेक हो रही है तैमूर.
सर
मेरे को बोलो ऑडियो बंद कर दे, ऑडियो वीडियो बंद कर दे.
सर वीडियो ऑफ है मेरी.
Oh, is that right? Okay.
ठीक है. CT MRI और
सर CT हो गया, MRI brain with contrast with pituitary protocol, and then patient should have perimetry, and then all the pituitary profile with all hormones like prolactin, T3, T4, TSH, growth hormone, insulin, like growth hormone.
अच्छा, एक बात बताइए, इसमें जो है, इसमें आप प्रोलैक्टिन लेवल क्या एक्सपेक्ट कर रहे हैं?
Sir, since the patient is not having any functional manifestation, so it could have been slightly raised due to the stroke effect. It could be it's a non-functional pituitary tumor probably, and
ठीक है. Dr. Juma, Dr. Lal Ahmad.
So, sir, should I show you the investigations?
Lal, please.
इसका सर ये हार्मोन्स में T3 T4 कम है, बाकी ठीक है, और बाइटेम्पोरल हेमिनोपे विजुअल फील्ड पे हैं. और should I show you the radiology?
ठीक है. जी.
ये उसका MRI है, और कट्स भी हमारे पास हैं.
जी डॉक्टर साहब, बताइए MRI में क्या देख रहे हैं आप?
Sir, MRI T1 weighted sagittal view of the patient showing a hypointense lesion in the sella, or isointense sort of, and that is extending in the suprasellar area, causing effacement of the optic chiasm. I would like to see the contrast images.
अच्छा, chiasma देखने के लिए कौन सा आपको चाहिए होगा स्कैन?
Sir, coronal view Johnson, वो I would like to see.
ठीक. चलिए, contrast हो गया.
ये coronal cuts.
Sir, on MRI T1 with contrast, coronal view showing a large contrast enhancing lesion in the cellular suprasellar region, and it's not encasing the internal carotid artery, and chiasm cannot be appreciated in this, cannot be seen.
ठीक है, तो फिर how you proceed further with this patient?
So in this case, we'll get the perimetry and the other pituitary profile of the patient.
बता
And
दिया already.
जी, ठीक है. So उसके बाद I would like to counsel the patient about the disease and its complication that he can have with complete vision loss and other derangement of the hormonal profile, and then I will let him know my surgical plan and its complications and its advantages. Once he agrees, then patient will be admitted, and meanwhile we will try to restore his thyroid hormone and with thyroxine, and then his blood-based investigations will be done. His rest of the journal and cardiac fitness will be taken, and patient should have CT with first protocol. Since I'm planning to do the transsphenoidal approach in this case, so I should know the anatomy of the sphenoid sinus as well, or even the plain X-ray lateral view. And once patient is prepared, then we'll put him on the elective list for transsphenoidal microsurgical transsphenoidal approach.
So आप करेंगे
Microscopic transsphenoidal approach.
एंडोस्कोपिक के बारे में क्यों नहीं सोचते आप?
Sir, actually हमारे center में we used to do only the microscopic, so that's why
अच्छा,
I'm
option
more
है.
comfortable with it. Yes sir,
But
options तो definitely है.
that option is there. Okay. ठीक. जुमा साहब आप कुछ पूछें सर?
जुमा साहब आप कुछ पूछ रहे हैं इनसे? 5 मिनट हम और इनसे वाइवा ले सकते, फिर वो टाइम खत्म हो जाएगा.
So, Dr. Saab, as you're preparing for the surgery in the operating room, any thoughts on preparation, positioning, वगैरह?
जी sir, patient once he's admitted and we are preparing it, we will start the Zynosine spray usually 3 days before. And once in the operation theater, patient is loaded with steroid and antibiotic, and a platelet soaked with adrenaline and xylocaine is placed in his middle meatus and the septum. Patient is given GA and put in the supine position with almost torso 15-degree elevated and neck slightly rotated for microscopic surgical approach. And after that, platelet is removed and nose is prepared with chlorhexidine, and we will start usually with the help of ENT surgeon, we will start with the nasal phase of the surgery. So should I tell all the steps?
No, because you've already started the operation, and I was just wondering whether you were going to insert a lumbar drain.
Okay, sir, usually in our setup we do not do it, but
Okay.
yes, it can.
No.
It can
So
be done.
That's surgeon choice, but quite often in a large tumor, the chances of producing a CSF leak are pretty high. But particularly if you're fortunate, because the tumor starts dropping down and the arachnoid follows it, the arachnoid in this tumor will be very thin, so the chance of causing a rent is pretty high. And then after you've lost CSF, to then put in a lumbar drain afterwards is quite difficult.
I agree, sir.
So there are some people, some very accomplished pituitary surgeons who put in a lumbar drain and then put in dyes at the start of every case. But anyway, I was wondering about that. Okay, Doctor, Lal, I think that's okay.
Yes, sir. Time. Okay, बस आप लोग उसको feedback सर दे दें. क्या? How was its performance?
I think मेरे हिसाब से तो is performed quite well.
Yeah.
Or
I think
if he performed.
So Masood, can I want your thoughts on this? I think Dr. Saab performed. I think Dr. Saab performed too well. मतलब यानी कि वो इतनी फुर्ती से हर सारी चीजों से आगे निकलते जा रहे थे.
Yes.
Whereas I think that I don't want you to waste time, but those areas where you think, you've taken the history, they've already figured out, okay, yaar, it's a 45-year-old guy who's got headache and bitemporal hemianopia. Now, the chance of being a pituitary case is very high. So in the history, I would linger a little bit on. So I would ask about loss of libido. I would ask about the age of the younger, how many children, the age of the youngest child. So in other words, how many years, and has he been trying for a family? I mean, so you linger on that a little bit. Whereas actually, you were asking, Dr. Sahab, quite frankly, again, आपने बहुत देख लिया है. आप मुझे ये बताओ, how often does a person with visual loss come and come with a growth hormone secreting tumor without there being an obvious change in the hand and feet and this, that, and the other? What I'm trying to say is, when you've got visual loss and you've got acromegaly, तो वो it's obvious. तो आप ये पूछना कि जी, I will then ask him, has he had noticed any change in the hands? Has he noticed any change in the feet? It's kind of almost superficial. But the other thing is more important. Linger on his loss of libido. Linger on his central gate ataxia, because he may be developing hydrocephalus. So in other words, whenever you're doing something, try not to rush through it, but convey that your questioning has a certain purpose, and that is to elicit all the features, all the endocrinological, neurological features of a pituitary adenoma. ठीक है, Dr. Sahab?
जी सर, जी सर.
But I would pass you, despite that.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you so much,
sir. आप लोगों ने टाइम दिया. और
thank you, Lal.
Thank you, sir.
Okay, जी, Allah.
Thank you so much. आप लोगों ने हमें इतना टाइम दिया.
Welcome.
Assalamu alaikum, sir.
Thank you, sir. Thank you, sir.
सर ये 20 मिनट्स तो सर लाल रहमान साहब से क्वेश्चन है सर. 20 मिनट्स तो बहुत कम है. हमें देखें फिर उसमें तो बहुत
देखिए मैं एक चीज बताऊं, ये जो 20 मिनट्स की बात है ना, इस तरह ये तो आज एक जनरल डिस्कशन थी, इस वजह से टाइम ज्यादा लगा. वहां पे आपको फोकस होगा, उसके सामने पर्ची होगी. जिस तरह शॉर्ट केस में होता है, शॉर्ट केस अगर कोई चीज हो तो उस पर कितना टाइम अगर बंदा चाहे लगा सकते हैं, लेकिन वो पे घंटी बजेगी, हर उसकी टाइम डिस्ट्रीब्यूशन होगी. तो ये नहीं है कि एग्जामिनर की मर्जी से नहीं जाएगी, बल्कि कॉलेज की मर्जी से सब कुछ होगा. तो घंटी बजेगी और फिर आगे से जो है ना आपका टाइम जब खत्म हो जाएगा, फिर दूसरा केस शुरू हो जाएगा. इस तरह नहीं हुआ जिस तरह आज तो हमने जरा लंबाई कर दी, क्योंकि इसमें डिस्कशन ज्यादा आ गई ना. लेकिन वहां पे जो टाइम है उसके मुताबिक होगा सब कुछ.
सर देखें, अगर वहां पे अगर एग्जामिनर पूछे आप अपनी स्टेप्स बताएं, फिर कॉम्प्लिकेशंस पे डिस्कशन अगर इसी तरह ही हो, तो हमारे तो फिर काफी सारे क्वेश्चन रह भी जाएंगे. नहीं,
खैर है, कुछ नहीं होता. आपने जो क्वेश्चन दी है बस वो आप देखिए. एफआरसीएस का जो एग्जाम मैं अभी दे के आ रहा हूँ जनवरी में, वहाँ पे 15 मिनट्स का लॉन्ग केस था, जिसमें वो जो है ना हिस्ट्री भी पूछी थी, एग्जामिनेशन भी करना था और मैनेजमेंट भी करनी, सब कुछ कर रहा था. तो ये 20 मिनट्स मेरे ख्याल में इट इज इनफ. इसमें आपने बिल्कुल टू द पॉइंट, यानी बिल्कुल आपने फोकस होना है कि भाई क्या क्या पूछेंगे, आपको इधर उधर चीजें में नहीं फंसाएंगे.
ठीक है सर.
और आप लोगों की रेडियोलॉजी और ये जो मैनेजमेंट है ये स्ट्रांग होनी चाहिए ना. बिल्कुल आपके सामने जब एमआरआई लग जाए तो आपने बिल्कुल उसको सही डिस्क्राइब करना है, और आपने डायरेक्ट, यानी मेरे ख्याल में ये एग्जाम आई थिंक इट विल बी इजी एज कंपेयर्ड टू द प्रीवियस एग्जाम्स. तो होपफुली इंशाल्लाह काफी लोग जरा पास होंगे इसमें, मुझे ऐसा लगता है इंशाल्लाह.
सर न्यूरो एनाटॉमी का थोड़ी सी एग्जांपल दे दें, मतलब वो किस तरह हमें.
न्यूरो एनाटॉमी वही होगा, आपके सामने उसने जो है ना एमआरआई लगा दिया, तो आपसे पहले उस पर डिस्कशन हो कि भाई ये फलां क्या चीज, इसका ड्यूरल टेल कहाँ पे है, इंटरनल अकूस्टिक मैट्रिक्स कौन सा है, फोर्थ वेंट्रिकल कहाँ पे, ये एनाटॉमी हो गई. रेडियोलॉजी भी होगा. और जब आप सर्जिकल इंटरवेंशन शुरू करेंगे तो आपने बरहोल कहाँ बनाना है, आपने जो है ना क्रेनियोटॉमी कहाँ तक करनी है, आपको कौन कौन से स्ट्रक्चर नजर आएंगे, फिर आप ड्यूरो खोलेंगे तो फिर क्या होगा, जब आप लेजन तक पहुंच जाएंगे तो कौन कौन से नर्व्स होंगे, फिर अच्छा इसके आगे क्या होगा, इसका जो एक्युलस कहाँ पे होगा, इसके इंटरनल. तो ये एनाटॉमी भी सर्जिकल अप्रोच में डिस्कस होगी सारी. दैट विल बी एनाटॉमी.
सर ये अलग से इसका स्पॉट नहीं होगा, यानी वो उसी लॉन्ग केस पे ही हो जाएगी जैसे.
बस उसी लॉन्ग के, यानी इसमें जो क्लिनिकल साइड और ये तकरीबन यूं समझे कि ये अप्लाइड टाइप एफ एनाटॉमी होगी। तो साथ साथ एनाटॉमी, सिर्फ एनाटॉमी नहीं होगा भाई, फलां चीज एनाटॉमी से रिलेटेड सर्जिकल क्वेश्चंस भी होंगे, वो एनाटॉमी से रिलेटेड डिफरेंशियल भी होगा, एनाटॉमी से रिलेटेड सब चीजें होंगी। तो दिस इज जस्ट लाइक जिस तरह पुराने जमाने में लॉन्ग केस में जो सब चीजें कवर होती थी, थोड़ा सा अलग होगा। लेकिन इसमें सिर्फ एनाटॉमी नहीं होगा, सिर्फ एनाटॉमी पूछे, एनाटॉमी से रिलेटेड जिस तरह मैंने बता दिया डिफरेंशियल भी एनाटॉमी वाइज और सर्जिकल इंटरवेंशन भी एनाटॉमी, सब चीजें सर होगी। तो ये इंटरमिक्स्ड होंगी सारी चीजें।
जी सर, जज़ाकल्लाह सर, थैंक यू सर।
इसमें वही चीज होंगी, आज हमने जो डिस्कस किया इसमें एनाटॉमी में डिस्कस हुआ, इसमें रेडियोलॉजी में डिस्कस, इसमें मैनेजमेंट, सब कुछ डिस्कस हुआ। आपके पास नॉलेज हो तो दिस इज नॉट ए प्रॉब्लम फॉर यू कि भाई वो क्या पूछ रहा है, लेकिन आपको जो है ना, अगर आपके पास नॉलेज और आपको जवाब आता हो तो आई थिंक इट विल बी वेरी इजी और आप लोग तैयार हो जाए। यही होगा जिस तरह हम कर रहे हैं आजकल, नथिंग विल बी डिफरेंट और इंशाल्लाह होपफुली रिजल्ट्स अच्छे होंगे।
थैंक यू सर।
तो कल कौन करना चाहते हैं? कल हम जरा जल्दी करेंगे।
सर इसमें जो, हेलो सर,
11:30 बजे, कल हम 11:30 बजे करेंगे, आप लोग तैयारी कर लें। कल 11:30 बजे होगा।
सर एक क्वेश्चन है।
3 केसेस होंगे, बस एक एक बंदा कर ले, जो चीज करने वो फौरन को बता दे जो करना चाहते हैं, ठीक है?
सर एक क्वेश्चन है सर।
जी 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 शाकिरुल्लाह साहब कुछ कह रहे थे आप?
सर इसमें जो 20 मिनट का सेक्शन होगा तो ये फिर एग्जामिनर चेंज होंगे?
मेरे ख्याल में एग्जामिनर वही 2 होंगे, चेंज नहीं होंगे।
चेंज नहीं होंगे,
लेकिन आई एम नॉट श्योर, ये मैं कुछ नहीं बता सकता। शायद एग्जामिनर चेंज होंगे सर, शॉर्ट केसेस में चेंज होते रहते, तो इसमें आई एम नॉट क्लियर, ये तो वहाँ पे डिसाइड होगा। लेकिन शायद चेंज हो एग्जामिनर, क्योंकि एग्जामिनर तो ज्यादा होंगे, 2 बंदे हैं, लेकिन जो हर एक स्टेशन पे 2 एग्जामिनर होंगे मेरे ख्याल में। आई एम नॉट श्योर, ये मेरे हाथ में बात नहीं है, लेकिन चूंकि 3 स्टेशन है तो मेरे ख्याल में हर स्टेशन पे 2 अलग अलग एग्जामिनर होंगे।
ओके, थैंक यू सर।
ठीक है जी, इंशाल्लाह फिर कल देखेंगे। कल हमारा 11:30 बजे शुरू होगा, क्योंकि कल हमने एक और सेशन के साथ ज्वाइन करना है, तो 11:30 बजे तैयार हो जाए, ठीक है? और टुमारो द एग्जामिनर विल बी डिफरेंट, वो अलग एग्जामिनर होंगे, ये लोग नहीं होंगे।
थैंक यू।
थैंक यू।
थैंक यू।